This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome back to the deep dive. Today we are cracking open a stack of critical clinical sources and doing a bit of a surgical strike into a region of the GI tract that's, well, often overlooked but deeply complex.
Yeah.
Small intestine. We're synthesizing information on disorders that lead to malabsorption, complex immune responses, and, the specific challenges presented by rare but pretty aggressive tumors.
That's absolutely right. And while, gastric and colonic issues tend to grab the headlines, small intestinal disorders, statistically, they account for about 10% of high-level clinical questions.
Right.
But they really pack a punch, covering everything from the sort of elegant failure of bile acid recycling to complex immune-mediated diseases like celiac and even the ultimate danger of aggressive lymphomas.
So our mission today is really to give you a structural understanding of the small bowel as a processing plant, like where and why things fail. We need to navigate this interconnected landscape pretty quickly, grasping the why behind seemingly disparate symptoms like chronic diarrhea, anasarca, and obscure GI bleeding. We're looking for those critical distinctions that guide diagnosis and treatment.
Exactly. The why.
Okay, let's unpack this, starting right at the heart of the matter. When the small intestine's primary job-absorbing nutrients goes completely sideways. So the first area that I think consistently separates the well-informed from the beginners is the outcome of an ileal resection. It seems simple. You cut out a piece of bowel, but the clinical result, and especially the treatment, it really hinges on one precise measurement.
Yeah, the length. And what's fascinating here is just how efficient the intrahepatic circulation, the EHC, normally is. This circulation is the body's recycling system for bile acids.
Okay.
Under normal conditions, the terminal ileum, that very last segment of the small bowel, it actively absorbs a staggering 95% of bile acids. Only about 5% is left to, exit the system.
95%. Wow.
Yeah, it's huge. And this active process is essential for maintaining the total bile acid pool, which in turn is essential for fat emulsification and absorption. So when you disrupt this system, the liver basically has to decide whether or not it can compensate.
And this leads us directly to that critical distinction that every learner really has to memorize, the aha moment that defines the entire treatment strategy. Let's look at the first scenario. A relatively small resection, specifically less than 100 centimeters of the terminal ileum.
Right. So if the resection is less than 100 centimeters, the remaining ileum is certainly impaired. Yeah. It can't capture all 95% of the bile acids it should. However, the liver is an incredible machine. It senses this mild impairment and it ramps up its synthesis rate to make up the difference.
It tries to catch up.
It tries. And crucially, the total bile acid content circulating in the EHC remains adequate. So because the systemic bile acid pool is maintained, fat digestion stays normal, meaning, and this is key, steatorrhea or fat malabsorption does not develop.
But the patient still presents with diarrhea, often quite severe. So where is that coming from if fat absorption is okay?
It comes from the small amount of unabsorbed bile acids that leak into the colon. Even though the overall pool is okay, that 5% that normally exits, plus a little extra from the impaired absorption, is now hitting the colon. And bile acids are potent mucosal irritants. They basically stimulate the colon to secrete water and electrolytes, causing a watery secretory diarrhea, which we specifically call cholorhaic diarrhea.
Cholorhaic, got it.
And since the problem is excess bile acids in the colon, the treatment is logical. You use bile acid sequestrants like cholesteronamine. They bind those irritating acids and prevent them from bothering the colon.
Okay, so if I'm a clinician, I need to remember less than 100 centimeters means the liver's working overtime but still compensating mostly. And the primary problem is a colonic irritation issue that we treat with a binder.
That's the crux of it.
Now, switch gears entirely. Sure. What happens when the resection crosses that 100-centimeter threshold? Big resection.
This is a fundamentally different disease state. Resecting more than 100 centimeters results in severe bile acid malabsorption. The sheer volume of the absorptive surface lost is just so great that the liver cannot possibly ramp up its synthesis enough to maintain the total bile acid pool.
It's overwhelmed.
Completely. The total content of bile acids in the EHC system drops significantly. And when the pool size drops below a critical concentration, it just can't effectively emulsify and absorb dietary fat anymore. That deficit leads directly to fat malabsorption or steatorrhea.
And this is where the treatment contrast becomes absolutely vital and potentially dangerous if you get it wrong. If you mistakenly give cholestyramine in this severe scenario, what happens?
You make everything much, much worse. Precisely. If you use a bile acids questionnaire when the patient already has a severe deficiency of bile acids, you are just removing more of what little they have left.
Oh, wow.
Which worsens the steatorrhea dramatically. So the treatment pivots entirely. We have to treat the symptoms of fat loss, a very strict low-fat diet, antidiarrheals, and often the use of medium-chain fatty acids, or MCFAs.
MCFAs. Why are they useful here?
The beauty of MCFAs is that they are water-soluble. They don't actually require bile acids for absorption. They can kind of bypass the entire failed EHC system and get absorbed directly.
That's clever. Okay, before we leave this section, we should quickly circle back to the why behind the diarrhea itself, independent of the bile acids. You mentioned the ileal break.
Ah, yes, the ileal break. See, the ileum isn't just an absorptive surface. It's a vital communicator in the gut. When nutrients, particularly fat and carbohydrates, reach the ileum, it secretes a hormone called peptide YY.
Peptide YY.
And this hormonal signal basically tells the upper GI tract, the stomach and duodenum, to slow down motility. It's a powerful negative feedback loop designed to maximize nutrient contact time for optimal absorption.
A break, essentially.
Exactly. It's the ileal break. So when you lose a significant portion of the ileum, you lose the primary source of this break, which contributes substantially to the rapid intestinal transit and the diarrhea seen post-resection, on top of any bile acid issues.
Okay, moving to the general topic of steatorrhea. Clinically, this is, well, usually hard to miss when it's significant. Greasy, oily, foul-smelling stools, significant weight loss, and the classic downstream effects of deficiencies in fat-soluble vitamins A, D, E, and K.
Yeah, you think of the bone disease from vitamin D deficiency, maybe night blindness from A, or the coagulopathy, the bleeding risk from vitamin K deficiency. It's systemic.
Right, and we generally categorize the causes into three big buckets: exocrine pancreatic insufficiency.
So the pancreas isn't making the enzyme.
Primary small intestinal mucosal disease.
Like celiac or Whipple's.
Or bile acid deficiency, which we just discussed with the large resections.
Correct. So the first step in a patient presenting with these symptoms is simply to prove that fat malabsorption is actually happening. We use two classical tests for this.
Okay.
The first is the simple rapid stool Sudan stain. It's a microscopic look, and it's positive if you see more than 5 fat globules per high-power field, quick and dirty.
And the second?
The second, more quantitative but also more cumbersome, is the fecal fat excretion test. This requires some effort. The patient has to consume 100 grams of fat daily for 3 days.
A high-fat load.
Yes, and then you collect stool for 24 hours. If they excrete more than 7 grams of fat per 24 hours, it quantifies and confirms steatorrhea. It's the gold standard measure, but obviously takes time and patient compliance.
Okay, once it's confirmed, the detective work begins to find the source. We use non-invasive tests like fecal elastase to check the pancreas.
Right. Low elastase points strongly to pancreatic insufficiency.
And tissue transglutaminase antibodies for celiac disease screening.
Yeah.
But the tool that truly isolates the small bowel's intrinsic health is the D-xylose test. Let's unpack that one.
The D-xylose test, yes. Here's where it gets really interesting because it's kind of an elegant way to eliminate confounding variables. D-xylose is a simple monosaccharide, just a 5-carbon sugar. The critical mechanism, the reason we use it, is that D-xylose absorption does not require bile acids for emulsification, nor does it require pancreatic enzymes for digestion. It's absorbed straight across the small intestinal mucosa, primarily via passive diffusion.
So, in essence, you're using D-xylose as a clean test of the enterocyte itself, the gut lining.
Exactly. You're testing the wall. If the patient drinks the D-xylose solution, and then you measure low levels in their blood, typically looking for less than 20 milligudl after 1 hour, or in their urine, less than 4 grams collected over 5 hours.
What does that tell you?
That low result strongly suggests the problem lies in the small intestinal mucosa itself. The absorptive capacity is impaired due to mucosal damage, maybe from something like celiac disease or tropical sprue.
But here's the critical flip side, the power of the test, a normal result.
Yes. A normal result means the mucosa is fine, the small bowel can absorb the D-xylose properly, therefore the etiology of the patient's steatorrhea must be somewhere else.
Like the pancreas or a bile acid issue.
Precisely. It pushes the diagnosis definitively toward pancreatic issues or bile acid deficiencies. It's a fantastic way to triangulate the source of the problem when you have steatorrhea, PLE.
All right, let's shift gears to protein-losing enteropathy, or PLE. This is a rare but dramatically symptomatic condition. It's defined by the excessive loss of serum proteins into the GI tract. And the key consequence is hypoproteinemia.
Yeah, low protein in the blood. And it's severe because the loss of albumin and globulins leads to a dramatic drop in plasma oncotic pressure.
Oncotic pressure, remind us.
That's the force generated by proteins, mainly albumin, that keeps fluid inside the blood vessels. When it drops because you're losing protein into the gut, fluid leaks out into the interstitial spaces, leading to widespread edema.
So that's the ascites, the pleural effusions, the severe generalized swelling known as anasarca. The patient looks almost universally swollen.
That's the picture. The causes generally fall into two crucial categories based on how the protein is lost. The first is pretty straightforward, frank VI mucosal disease,
where the surface is just damaged and leaky.
Exactly. We see this in severe gastritis, inflammatory bowel disease, IBD, celiac disease, or Whipple disease. The lining itself is compromised.
Okay, but the second category is maybe less intuitive. It's related to pressure.
Yes, increased mucosal interstitial pressure. This category involves issues that compromise lymphatic or venous outflow from the gut wall. This back pressure essentially forces protein-rich lymph or plasma to leak into the gut lumen.
Examples.
Classic examples include intestinal lymphangiectasias, which are dilated lymph vessels, or severe portal hypertension, where pressure backs up from the liver, or even certain heart diseases that cause high central venous pressure like constrictive pericarditis, severe congestive heart failure, or complications after the Fontan procedure for congenital heart defects. Anything that increases back pressure on the gut.
So to diagnose this, we need a definitive measurement of enteric protein loss. The gold standard cited in our sources is the alpha-1 antitrypsin clearance test, A1AT clearance.
Right. A1AT clearance is used because alpha-1 antitrypsin is a medium-sized protein that's naturally resistant to degradation by typical intestinal proteases. It's normally filtered out through the gut wall in only very small amounts.
Okay.
However, we must stress, and this is really important for accuracy, that the diagnosis requires a 24-hour stool collection. A spot measurement, just a single sample, is notoriously unreliable for clearance calculations.
Right, need the whole 24 hours.
Yeah.
But here is the major diagnostic hurdle, the risk of a false negative if the protein loss is actually coming from the stomach. Why is pepsin degradation such a common pitfall here?
Yes. Because A1AT is resistant to the enzymes in the small intestine, but it is not resistant to pepsin, which is the main protease active in the acidic environment of the stomach.
Okay, so if the leak is gastric.
If the patient has severe gastric protein loss, say from massive erosive gastritis or something like Menetriers disease, the pepsin in the stomach breaks down the A1AT before it ever reaches the colon for collection.
So the test looks normal, but it's wrong.
Exactly. It causes a false negative result suggesting no enteric loss when in fact there's significant gastric loss. To preempt this, patients are strongly recommended to take proton pump inhibitors, PPIs, for several days prior to and during the stool collection.
Why PPIs?
By suppressing gastric acid, you significantly reduce pepsin activity. This preserves the A1AT even if it's lost in the stomach, allowing the test to accurately reflect the total enteric protein loss, whether it's gastric, small intestinal, or colonic.
That makes the test almost a two-step process in practice. Ensure gastric acid is neutralized with PPIs, then collect the 24-hour stool sample to measure total loss. That's a critical clinical pearl, and if we need to visually pinpoint where the leakage is happening.
Then we can use advanced imaging like technetium 99-meter labeled albumin scintigraphy. You basically inject the radio-labeled albumin, and then nuclear scanning is used to visually detect where the tracer is leaking out of the blood vessels and pooling in the abdomen. It can help identify the site of protein loss stomach, specific loops of small bowel or colon.
Okay, let's touch briefly on carbohydrate malabsorption. This is generally a bit easier to screen for using some simple chemical clues in the stool that suggest fermentation is occurring where it shouldn't be, or to excess.
Right. The simple diagnostic signs are, firstly, a low fecal pH, specifically less than 5.5. Normally, stool pH is around 6.5 to 7.5.
Why low?
Because unabsorbed carbs get fermented by colonic bacteria into short-chain fatty acids, which, as the name suggests, are acidic. This lowers the stool pH.
Makes sense. And the second clue?
And an increased stool osmotic gap, typically greater than 100. This gap represents the difference between the measured osmolality of the stool water and the calculated osmolarity based on electrolytes, mainly sodium and potassium.
So the high gap means?
A high osmotic gap tells you that there are unmeasured osmotic particles like undigested carbohydrates pulling water into the lumen, causing osmotic diarrhea.
Okay, simple clues. For confirmation, the hydrogen breath test remains a staple, right? The mechanism is pretty neat.
It is simple and elegant. Unabsorbed carbohydrates like lactose or fructose are fermented by bacteria, primarily in the colon, but sometimes in the small bowel if there's overgrowth. This fermentation produces hydrogen gas, H2.
And we measure that.
Exactly. The H2 is absorbed into the blood, transferred to the lungs, and then measured in the exhaled breath. An abnormal test typically shows a rise greater than 20 parts per million of hydrogen compared to the baseline level after ingesting the test sugar.
But we always have to note the limitations, the caveats.
Absolutely. First, if the patient has small intestinal bacterial overgrowth, SIBO, which we'll get to next, that can cause a false positive. The fermentation happens too early in the small bowel, mimicking malabsorption.
Okay. And the other way?
False negatives can occur if the patient is currently taking antibiotics or has recently taken them. Antibiotics can wipe out the bacteria needed for fermentation, so even if carbs aren't absorbed, no hydrogen is produced.
Got it. And finally, specifically for diagnosing lactose intolerance, we often use the lactose tolerance test. This is a blood-based test, not breath.
Correct. Here, the patient ingests a standard dose, usually 50 grams of lactose, and then we measure their blood glucose levels over the next couple of hours.
What are we looking for?
If the lactose is properly digested by the enzyme lactase in the small intestine, it breaks down into glucose and galactose, which are absorbed, causing blood glucose to rise. If the patient's blood glucose rises by less than 20 milli-GDL within 2 hours and they develop their typical symptoms, bloating, cramps, diarrhea,
And that confirms it.
then that confirms the failure to break down and absorb the lactose, indicating lactase deficiency or lactose intolerance.
All right. SIBO, small intestinal bacterial overgrowth. This is, one of the most talked about topics in GI health right now, it seems.
It really is. And fundamentally, SIBO is a disruption of the body's natural microbial gradient. Think of it like a firewall between the relatively clean small intestine and the densely populated colon.
Okay.
The definition is either an increase in the sheer number of bacteria or a change in the type of bacteria found in the small intestine, usually colonic-type bacteria moving upstream.
And that gradient is normally pretty steep, right?
It's truly remarkable and maintained by several factors.
Yeah.
Stomach acid killing ingested bacteria, normal intestinal motility flushing things forward, and the ileocecal valve acting as a barrier preventing backflow from the colon. In the stomach and duodenum, we see a really low density, maybe 103 T33 colony-forming units per milliliter.
Very low.
But in the colon, that density explodes to between $10 and 1013 CFU/ml, just massive numbers. SIBO occurs when the small intestine starts adopting that high-density colonic-type environment too far proximally.
And that leads to symptoms?
Yes, often diarrhea due to bacterial effects on bile acids and carbs, but probably the most common symptoms reported are excessive gas and bloating, abdominal distension.
The underlying risk factors are crucial because successful treatment really hinges on addressing the root cause, if possible. What kind of things predispose someone to SIBO?
We think about anatomical issues, things that create stagnant areas where bacteria can multiply, like blind loops after surgery, fistulas between bowel segments, or strictures maybe from Crohn's disease.
Stagnant pools.
Exactly. Then we look for motility disturbances, where the bowel just isn't moving bacteria forward effectively. Think diabetic neuropathy affecting gut nerves, scleroderma stiffening the bowel wall, or even chronic opiate use, which slows transit.
Makes sense.
And, as we mentioned with carbohydrate testing, there's a significant risk posed by acid suppression, particularly long-term PPI use or conditions like achlorhydria, where stomach acid is absent. Stomach acid is a critical defense mechanism against oral bacteria colonizing the small bowel. Removing that defense definitely increases the risk. Other diseases like celiac or cystic fibrosis are also associated.
Diagnosis, however, seems to be a persistent challenge. What's the gold standard, technically?
The invasive gold standard is still considered a proximal jejunal aspirate, where you actually sample fluid from the upper small bowel during endoscopy and culture it. Finding PACL 103 text CFU/ml is diagnostic.
But that's invasive, not done routinely.
Not at all routinely. So in clinical practice, we rely almost entirely on breath tests, usually using either lactulose or glucose as the substrate.
And we use those defined abnormal rise criteria again.
Yes, typically looking for a rise greater than 20 ppm in hydrogen within 2 hours for lactulose, or a bit stricter, greater than 12 ppm within 3 hours for glucose. But we have to dedicate significant time here to the critical caveat, the thing that leads to potentially massive rates of misdiagnosis, the issue of rapid intestinal transit causing a false positive.
Okay, explain that clinical scenario. If I get an early peak on a breath test, say at 60 minutes, how do I know if that was fermentation happening way up in the duodenum, which would be true SIBO, or if it was fermentation happening down the colon because the sugar just got there super fast?
That is the $10,000 question, maybe the $1 million question in SIBO diagnostics. In a patient with hypermotility, maybe from IBSD or post-surgical changes, the lactulose substrate might just zip through the small bowel and reach the cecum, the start of the colon, in maybe 60 or 90 minutes.
Much faster than usual.
Much faster. And the colonic bacteria are incredibly dense and metabolically active. They immediately begin fermenting that lactulose, causing a sharp early hydrogen peak. Because that peak occurred early, within the typical SIBO window, it mimics the timeline of fermentation you'd expect in the proximal small bowel.
So it looks like SIBO, but it's not.
Exactly. It leads to a false positive SIBO diagnosis. The clinician then ends up treating SIBO that isn't actually there, often with repeated courses of antibiotics, while the patient's underlying motility disorder, the real cause of their symptoms, goes unaddressed.
So how do we definitively confirm if that hydrogen peak occurred before the substrate actually reached the colon? How do we establish that crucial timestamp?
This is where the advanced technique of scintigraphy becomes invaluable, although it's certainly not routine or widely available. You'd repeat the breath test, but this time the ingested test meal, containing the lactulose or glucose, is also labeled with a non-absorbable radioactive tracer, like technetium-99 labeled sulfur colloid.
So you track it visually?
Yes, the nuclear scanning literally tracks the meal's progress through the gut. If the hydrogen peak on the breath test occurs after the scanner confirms the radio tracer has arrived in the cecum, the entrance to the colon, then you know with certainty that the fermentation was colonic.
Ah, definitive proof.
It definitively rules out SIBO in that scenario and confirms that the patient's symptoms are likely due to rapid transit, not bacterial overgrowth in the small bowel. It's a powerful tool for untangling these tricky cases.
That is a phenomenal use of technology to solve a very common diagnostic pitfall. Before we move on, we should probably briefly mention intestinal methanogenic overgrowth, or IMO, which isn't strictly SIBO, but often gets lumped in.
Good point. IMO is important because it involves different organisms. They're archaea, not true bacteria, primarily Methanobrevibacter smithii. These organisms consume the hydrogen produced by other bacteria and metabolize it to produce methane, CH4.
And clinically, that presents differently.
Often, yes. Methane itself is known to slow intestinal transit, so IMO is more commonly associated with constipation and bloating, rather than the diarrhea often seen with classic hydrogen-producing SIBO. Diagnosis involves specific breath tests that measure both hydrogen and methane levels. Treatment might also differ slightly, sometimes requiring combination antibiotics.
Okay, so treatment for typical SIBO involves addressing underlying causes if possible, maybe dietary changes like a low carbohydrate or low FODMAP diet, and the core therapy is usually antibiotics.
Rifaximin seems to be the preferred agent.
Rifaximin is generally preferred, yes. It's considered safest and often most effective because it has extremely low systemic absorption. It stays concentrated right there in the gut lumen where the overgrown bacteria are, minimizing side effects elsewhere in the body. But it is expensive, and insurance coverage can be an issue. So alternatives like amoxicillin clavulanic acid, doxycycline, metronidazole, or others are sometimes used, often based on availability, cost, and suspected type of bacteria.
And the frustrating part. Recurrence is common, very common, because unless you can fix the underlying anatomical or motility problem, the bacteria tend to grow back. This is a major clinical frustration, often necessitating repeated courses of antibiotics or rotating therapies.
Okay, moving from overgrowth to, well, the opposite problem.
Yeah.
Not enough bowel. Short bowel syndrome, SBS. This represents the ultimate failure of small intestinal capacity, right?
It really does. It's formally defined as intestinal failure, resulting from a significant reduction in the normal small intestinal length, usually down to less than 30% or less than 200 centimeters remaining in adults. This is a severe, often life-altering form of malabsorption.
What causes such drastic loss?
It's usually due to catastrophic events, things like mesenteric vascular events, clots cutting off blood supply leading to infarction and massive resection, midgut volvulus, where the bowel twists on itself, severe Crohn's disease requiring multiple extensive resections over time, or major abdominal trauma.
And the patient's survival and quality of life often depend heavily on whether they still have a functional colon.
Absolutely. The presence of the colon provides partial but crucial compensation. The colon is excellent at absorbing water and electrolytes, and it can also salvage some energy from unabsorbed carbohydrates through fermentation into short-chain fatty acids. Having a colon significantly improves fluid balance and nutritional status in SBS patients.
We have some clear markers that help predict a patient's dependency on total parenteral nutrition, TPN, for survival, basically intravenous feeding. Obviously, the remaining length is key.
Yeah, extremely short remaining length, usually cited as less than 50 to 100 centimeters of small bowel, is the strongest predictor of long-term TPN dependency.
What else?
Two other markers are really important. First, low plasma citrulline levels. Citrulline is an amino acid that's synthesized almost exclusively by healthy enterocytes, the cells lining the small intestine. So low blood levels are a direct, quantifiable biomarker of poor remaining mucosal mass and function.
A measure of gut health.
Exactly. Second, the absence of the ileocecal valve or a functional colon. The ileocecal valve acts as a natural brake, slowing transit from the small bowel into the colon, and it also helps prevent colonic bacteria from refluxing back into the small intestine. Losing it accelerates transit and worsens malabsorption, and as we said, the colon itself is vital for fluid absorption.
Okay, the complications of SBS are varied and highly specialized. We definitely need to discuss D-lactic acidosis. It's rare, but clinically very important when it occurs.
It is. D-lactic acidosis is a direct result of that reduced absorptive capacity. The drastically shortened small bowel just cannot absorb dietary carbohydrates effectively. This results in a huge load of undigested carbs being delivered directly to the colon.
And the colon bacteria have a field day.
They do. Specific colonic bacteria, often lactobacillus species, metabolize these unabsorbed carbs, but they produce D-lactate, which is an isomer, a mirror image of the L-lactate our bodies normally produce and handle.
And we can't metabolize D-lactate well.
Our human metabolism processes D-lactate very poorly, so when it's produced in large amounts by colonic bacteria and absorbed, it accumulates in the serum.
And when this D-lactate accumulates, we see the classic, frankly, terrifying neurologic symptoms.
Yeah, it's primarily a neurologic syndrome. Altered mentation, confusion, slurred speech, hallucinations, ataxia, loss of coordination, and general weakness or malaise. It can look like drunkenness or encephalopathy.
How is it diagnosed and treated?
The diagnosis is often clinical, especially when the symptoms occur after a high-carbohydrate meal in a known SBS patient. It can be confirmed by specialized D-lactate assays in the blood, which aren't routine lactic acid tests. Treatment is critical. Immediately withhold carbohydrates to cut off the substrate for the bacteria and aggressively treat the bacterial overgrowth, often with antibiotics like metronidazole or vancomycin, to eliminate the D-lactate producing bacteria. Sometimes IV fluids and bicarbonate are needed if the acidosis is severe.
Okay, that's D-lactic acidosis. The second major complication links directly back to our earlier discussion on steatorrhea, that's hyperoxaluria, and the formation of oxalate kidney stones. This sounds like a complex chain reaction.
It is a perfect example of a system failure in the gut cascading into a problem in a distant organ, the kidney. So remember, in SBS with significant bowel loss, you often have steatorrhea, lots of unabsorbed fat in the lumen.
Right.
Normally, dietary calcium binds dietary oxalate in the intestinal lumen, forming insoluble calcium oxalate, which is then excreted harmlessly in the stool. Very little oxalate gets absorbed.
Okay, standard process.
But when there's lots of unabsorbed fat around, that fat preferentially binds the dietary calcium instead. This is called saponification, basically forming soaps.
So the calcium is tied up with fat.
Exactly. This leaves the dietary oxalate unbound and free. This free oxalate, instead of being bound to calcium and excreted, now readily binds sodium, forming soluble sodium oxalate. And this soluble form is absorbed in much higher amounts, particularly in the colon.
So the colon absorbs the excess free oxalate.
Precisely. This excessive oxalate absorption leads to hyperoxaluria, high levels of oxalate in the urine, and that significantly increases the risk for the formation of calcium oxalate kidney stones.
It's a crucial distinction, though. If the SBS patient doesn't have a colon, for example, they have an endoileostomy, this enteric hyperoxaluria generally doesn't occur, right?
Mm-hmm.
Because the primary site of that excess oxalate absorption is the colon.
That's a key point. Presence of the colon is necessary for this specific complication. Management involves treating the steatorrhea if possible, a low oxalate diet, and ensuring adequate calcium intake with meals to bind oxalate in the gut before fat can bind the calcium.
Okay, now let's talk about advanced management for SBS, specifically the trophic agents used to try and enhance bowel adaptation, make the remaining gut work better.
Teduglutide, which is branded as Gattex, is the key agent here. It's a long-acting analog of glucagon-like peptide 2, or GLP-2. GLP-2 is a naturally occurring peptide hormone secreted by intestinal L cells in response to nutrients.
And what does it do?
Its function is profound for the gut lining. It enhances intestinal adaptation. It stimulates enterocyte proliferation, makes more gut cells, increases villus height and crypt depth, improves mucosal barrier function, and ultimately enhances fluid and nutrient absorption. It literally helps the remaining small gut grow and work better, potentially reducing TPN dependence.
That sounds incredibly beneficial. But there is a crucial risk associated with this therapy that necessitates rigorous screening beforehand.
Absolutely critical.
Because
GLP-2 is a potent trophic proliferative agent. It makes cells grow. Teduglutide carries a theoretical and, based on animal studies and caution, a very real risk of accelerating latent or pre-existing neoplastic growth, basically promoting cancer growth.
So active cancer is a no-go.
Active GI neoplasia is an absolute contraindication. And before starting any patient on teduglutide, the sources strongly recommend performing a thorough endoscopic evaluation of the remaining bowel, including colonoscopy if the colon is present, and removing any polyps found. This is to mitigate the risk of inadvertently accelerating a cancer that we didn't know was already there. Regular surveillance endoscopy may also be needed during treatment.
That's a really important safety consideration. Finally, for those patients whose intestinal adaptation fails despite dietary management and possibly teduglutide, SBS is the most common indication for intestinal transplantation. How are the outcomes there?
Outcomes have improved dramatically. Thankfully, recent data show excellent results, with a one-year patient survival rate after intestinal transplant now reaching about 90%. It remains a complex procedure with significant risks, including rejection and infection, but it's a life-saving option for patients with irreversible intestinal failure.
Okay, let's transition now to celiac disease. This is the classic example of an immune-mediated enteropathy triggered by the ingestion of gluten proteins found in wheat, barley, and rye in genetically susceptible individuals.
Mm-hmm.
While the prevalence in the U.S. is estimated around 1 in 141, maybe even 1 in 100, the vast majority of these cases, maybe 80% or more, remain undiagnosed. They exist in a state of sort of clinical silence or perhaps misdiagnosis.
Yeah, the problem isn't just the prevalence, it's the truly astonishing diversity of its presentation. Beyond the sort of classic picture of GI symptoms, chronic diarrhea, steatorrhea, weight loss, abdominal pain, celiac is genuinely a systemic disease.
Right.
Clinically, we often see it presenting first or solely as non-GI manifestations, most notably things like refractory iron deficiency anemia that doesn't respond to oral iron, metabolic bone disease like osteopenia or osteoporosis, even in younger people, infertility or recurrent miscarriages, chronic fatigue, neurologic symptoms like ataxia or neuropathy, the list is long.
And it's also strongly associated with other autoimmune conditions.
Very much so, particularly type 1 diabetes mellitus, autoimmune thyroid disease like Hashimoto's or Graves', autoimmune liver disease, Sjogren's syndrome, and also certain genetic conditions, most notably Down syndrome and Turner syndrome, have a much higher prevalence of celiac disease.
And the dermatologic manifestation is so specific, so pathognomonic that it really deserves its own discussion. Dermatitis herpetiformis, or DH.
DH is quite unique. It presents as intensely itchy, pruritic, grouped papules and vesicles. They look like little blisters or bumps, often clustered together, and they typically occur symmetrically on the extensor surfaces, elbows, knees, buttocks, back of the neck, or scalp.
And the link to celiac is incredibly strong.
Astonishingly strong. It's seen in maybe 15 to 25% of celiac patients. But the striking fact is that nearly 100% of patients diagnosed with DH have underlying celiac disease on intestinal biopsy, even if they have absolutely no gut symptoms.
Wow. So finding DH basically means the patient has celiac. How do you confirm DH?
The definitive diagnosis of DH is through a skin biopsy taken from uninvolved skin immediately adjacent to an active lesion. You're looking for granular IgA deposition in the papillary dermis, right at the dermo-epidermal junction, using immunofluorescence. That IgA deposit is the hallmark.
Okay. Now, the diagnosis of celiac disease itself comes with one absolutely unshakable rule for the clinician, right?
Yes. The cardinal rule for serologic testing, blood tests, and for the intestinal biopsy to be accurate, the patient must be consuming a gluten-containing diet.
Why is that so critical?
Because if they've already self-started a strict gluten-free diet, GFD, the antibodies in the blood can disappear and the inflammation and damage in the intestine can heal, sometimes quite quickly. This means the tests can become falsely negative, leading to a misdiagnosis or diagnostic uncertainty. Patients need to be eating gluten regularly, usually for at least 4 to 6 weeks before testing.
That's a huge practical point. So, assuming they're eating gluten, serology usually begins with
the IgA tissue transglutaminase antibody, or IgA-TTG. This test has very high sensitivity and specificity, making it the best first-line screening test in most people. We usually also check total IgA levels at the same time because if someone has IgA deficiency, which is more common in celiac patients, their IgA-TTG will be falsely negative. In that case, you'd need to use IgA-based tests, like IgA-DGP or IgG-TTG.
Okay, so IgA-TTG is the workhorse. If that's positive, the next step in adults is almost always
a small intestinal biopsy, usually from the duodenum, obtained during an upper endoscopy. This is still considered essential for confirming the diagnosis in adults to assess the degree of damage and to rule out other conditions.
Before we get to biopsy, let's touch on the genetics. There's an invaluable tool here for ruling out celiac disease, the HLA-DQ2 and HLA-DQ8 genes.
Yes, this is incredibly useful. Celiac disease is strongly associated with specific human leukocyte antigen, HLA class II genes. The vast majority of patients, somewhere between 90 to 95%, carry the HLA-DQ2 haplotype. Most of the remaining patients, maybe 5 to 10%, carry the HLA-DQ8 haplotype.
So if you don't have either of those,
that's the power. Because these genes are essentially required for the immune system to present the gluten peptides and trigger the inflammatory reaction, the absence of both HLA-DQ2 and HLA-DQ8 makes celiac disease extremely unlikely. It effectively rules out the diagnosis with a negative predictive value, NPV, approaching 100%.
So it's not good for ruling in the disease because many people have the genes but not the disease.
Exactly. About 30% of the general population has DQ2 or DQ8.
But it's fantastic for ruling it out. This is invaluable, for example, when managing patients who have already started a GFD before being tested, or maybe in first-degree relatives who are asymptomatic. If they lack the genes, you can confidently tell them they are highly unlikely to ever develop celiac disease.
It saves a lot of unnecessary endoscopies and gluten challenges in those situations.
Okay, back to histology. Biopsy remains the gold standard for confirmation in adults. Endoscopically, you might see some suggestive signs like scalloping of the duodenal folds or maybe fissuring or nodularity, but these visual cues aren't always present or reliable.
Right. They have fairly low sensitivity, maybe only seen in 50% to 60% of cases, especially milder ones. Therefore, multiple mucosal biopsies, usually at least 4 from the second or third part of the duodenum, plus maybe 1 or 2 from the duodenal bulb, are always required for diagnosis, even if the duodenal mucosa appears macroscopically normal to the endoscopist.
And what are we looking for under the microscope? We use the Marsh classification.
Yes, the Marsh classification, or variations like Marsh-Oberhuber, is used to grade the histologic severity. It ranges from Marsh I, which shows only an increase in intraepithelial lymphocytes, IELs. These are immune cells within the epithelial lining. The cutoff is generally 25 or 30 IELs per 100 enterocytes, but with normal villus architecture. Then you progress through Marsh-Sake, IELs plus crypt hyperplasia, to Marsh III, which involves villus atrophy, blunting or flattening of the villi. Marsh III is further subdivided into IIFIA, mild, IIB, moderate marked, and IIC, total villus atrophy, completely flat mucosa.
So a spectrum of damage. Now this brings us to a really challenging clinical situation. Non-responsive celiac disease, sometimes called NRCD. This is when a patient has persistent or recurrent symptoms despite supposedly adhering to a strict gluten-free diet, GFD, for a significant period, usually 6 to 12 months.
Yeah, this is common and often frustrating. The first thing to consider, and by far the most common cause of persistent symptoms, is ongoing gluten exposure.
So, noncompliance.
Often inadvertent noncompliance. Gluten is hidden in so many processed foods, medications, even things like communion wafers or cross-contamination in kitchens. It requires meticulous dietary review with an expert dietitian, maybe repeat serology if antibodies haven't normalized, sometimes even looking for gluten peptides in stool or urine to confirm ongoing exposure. You also need to reconsider the initial diagnosis. Was it definitely celiac? And rule out other overlapping conditions like IBS, SIBO, lactose intolerance, microscopic colitis.
Okay, so rule out gluten exposure and other diagnoses first. But if compliance seems perfect and other causes are excluded, we then enter the much more serious territory of true refractory celiac disease, or RCD.
Correct. RCD is formally defined by persistent or recurrent malabsorptive symptoms and persistent severe villus atrophy, like Marshall-May or IC, on biopsy, despite confirmed strict adherence to a GFD for at least 12 months. This is rare, maybe affecting 1–2% of celiac patients. And RCD is crucially divided into type 1 and type 2.
What's the difference?
Type 1 RCD is less severe.
Yeah.
The intraepithelial lymphocytes, IELs, on biopsy look relatively normal immunophenotypically. They are polyclonal, meaning they represent a diverse population of T cells. Type 1 RCD still carries increased morbidity, but the prognosis is relatively better, with a 5-year survival rate estimated around 90%. It might respond to immunosuppressive therapies like steroids or budesonide.
Okay, that's type 1. But type 2 RCD is the real clinical red flag.
Type 2 RCD is the danger zone. It is defined by the presence of an abnormal clonal population of IELs within the epithelium. These IELs often display aberrant immunophenotypes on flow cytometry or immunohistochemistry. Example, they lose surface CD3 or CD8 markers or express intracellular CD3. These are essentially T cells that have started to behave pre-malignantly, a low-grade intraepithelial lymphoma.
And the prognosis here is much worse.
Much, much worse. Type 2 RCD often responds poorly to treatment, is associated with more severe malnutrition, and has a terrible prognosis, with 5-year survival rates dropping below 50%. And the primary reason for this poor outcome is its high risk of progression, maybe 30–50% over 5 years, to an overtly aggressive, usually fatal malignancy.
Enteropathy-associated T-cell lymphoma, EATL.
Exactly, ETL.
It's really chilling to realize that a failure to manage or diagnose celiac disease strictly, leading down the path to type 2 RCD, can directly result in an aggressive cancer with a median overall survival often cited as only 10 months.
It underscores the critical importance of diagnosing celiac correctly, ensuring strict GFD adherence, and investigating non-responders thoroughly, including considering repeat biopsy with specialized IEL analysis if RCD is suspected. The distinction between type 1 and type 2 refractory disease, based on the clonality of those lymphocytes, is truly a matter of life and death.
Okay, shifting gears now to an infectious cause that can mimic many systemic diseases, including celiac sometimes. Let's talk about Whipple disease.
Whipple disease. This is a rare, chronic, multisystemic infectious disease. It's caused by the gram-positive rod-shaped bacterium Triforima whippli. And classically, it affects predominantly middle-aged white men, though it can occur in others.
And the clinical hallmark is really its multisystemic involvement, right? It makes it a great masquerader.
Absolutely. Patients often present initially with non-specific constitutional symptoms like low-grade fever, maybe lymphadenopathy. Arthralgia's joint pains are very common, often migratory, involving large joints and typically non-deforming, meaning they don't destroy the joint like rheumatoid arthritis might.
And the GI symptoms.
Abdominal pain, chronic diarrhea, and profound weight loss due to malabsorption are classic features, often developing later in the disease course. Staturia is common.
But the clinical clues can become truly unforgettable, almost unique, when the central nervous system gets involved. Cognitive dysfunction, like memory problems or personality changes, is relatively common in neurologic Whipples. But there's a pathognomonic finding, though rare, that if you see it, you should immediately think Whipples.
Ah, yes, the famous oculomasticatory myarrhythmia, or sometimes it's called oculofacial skeletal myarrhythmia.
Describe that.
It's bizarre. It involves slow, rhythmic, continuous movements of the eyes, often a pendular vergence nystagmus where the eyes converge and diverge smoothly, combined with simultaneous rhythmic movements of the jaw muscles, masticatory muscles, and sometimes facial or other skeletal muscles. It's very distinctive.
Well,
While it's present in less than 20% of patients with neurologic Whipples, seeing it practically screams Whipple's disease until proven otherwise.
okay, but since that sign is rare, the definitive diagnosis usually relies on microscopy, specifically requiring an intestinal biopsy.
Yes. The diagnosis is typically confirmed by demonstrating the characteristic infiltration of the lamina propria of the small intestine, obtained via endoscopy, with large, foamy macrophages.
Foamy macrophages.
But critically, these macrophages must stain positive with the periodic acid shift stain, the PAS stain. They are PAS positive. That positive PAS reaction results from the high amount of glycoprotein present in the cell walls of the ingested but undigested T. whipple organisms that accumulate within the macrophage lysosomes. Sometimes you can also see the bacilli themselves with electron microscopy or confirm with PCR for T. whipple DNA on the tissue or other fluids like CSF if neuroinvolvement is suspected.
Got it. PAS-positive foamy macrophages in the lamina propria. The treatment is complex, particularly because of the need for CNS penetration to prevent devastating neurologic relapse, right?
That's absolutely crucial. Treatment failure or relapse often manifests neurologically, which can be irreversible. So the recommended treatment requires a two-stage approach to ensure eradication, especially from the CNS.
What's stage 1?
The initial phase usually involves intravenous antibiotics that cross the blood-brain barrier well. Typically, ceftriaxone, sometimes penicillin G, given daily for about 2 to 4 weeks.
And stage 2?
That's followed by a long maintenance phase, usually for a full year, using oral trimethoprim sulfamethoxazole, TMPSMX, Bactrim, or Septra, because it also has good CNS penetration and is effective against T. whipple.
A whole year of antibiotics.
Yes. It's important to note that single-agent tetracycline, which was used historically, is no longer recommended as first-line therapy due to an unacceptably high rate of relapse, particularly neurologic relapse. Whipple's requires aggressive and prolonged treatment to ensure cure.
All right, let's move into the final section. Neoplasms of the small intestine. Small intestinal tumors are, thankfully, relatively uncommon compared to cancers in the stomach, or especially the colon. They might represent only about 2–3% of all GI malignancies.
That's right, they're rare. But they absolutely must be kept high on the differential diagnosis list for patients presenting with certain clinical scenarios, particularly obscure GI bleeding where standard endoscopy is negative, or unexplained abdominal pain, weight loss, or signs of obstruction.
When we think about the prevalence of different types and where they tend to occur, there seems to be a useful sort of geographic structure to remember.
There is. Adenocarcinoma, which is actually the most common primary malignant tumor of the small bowel overall, tends to favor the proximal small intestine, usually the duodenum and the proximal jejunum, closer to the stomach.
Okay, adenocarcinoma proximal. What about carcinoid tumors?
Carcinoid tumors, which arise from neuroendocrine cells in the gut wall and are now more properly called neuroendocrine tumors or NETs, have a predilection for the distal ileum, way down near the end of the small bowel.
Got it. Carcinoid nets distal. And lymphoma.
Lymphoma can potentially occur throughout the small intestine, but certain types often target the ileocecal region, right where the small bowel joins the colon. Benign tumors like adenomas, lipomas, or leiomyomas can also occur but are less common causes of major symptoms.
And as we've seen repeatedly today, underlying chronic inflammation and immune dysregulation seem to act as powerful risk factors for malignancy here too.
Definitely. We already hammered home the link between refractory celiac disease and EATL, a type of lymphoma. Celiac disease also slightly increases the risk for small bowel adenocarcinoma.
And Crohn's disease.
Crohn's disease, particularly due to the chronic inflammation, scarring, and potential fistula formation, also significantly increases the risk for small bowel adenocarcinoma, especially in areas of chronic disease activity. And certain lymphomas might be slightly more common too.
And we also must remember the inherited cancer predisposition syndromes.
Yes, absolutely. Hereditary syndromes like Poitts-Jeghers syndrome associated with hamartomatous polyps, familial adenomatous polyposis, FAP, and Lynch syndrome, HNPCC, all carry significantly increased risks for small bowel adenocarcinoma, particularly duodenolampulary cancer and FAP and Lynch. Hashtag 4.2 small intestinal lymphoma, B-cell and T-cell.
Okay, let's drill down specifically into small intestinal lymphomas. These are a fascinating but diverse group, usually categorized based on their cell of origin into B-cell and T-cell lineages. Let's start with the B-cell lymphomas found here.
One important type, particularly in certain geographic regions, is immunoproliferative small intestinal disease, or IPSID. It's sometimes called Mediterranean lymphoma because it's the most common type of GI lymphoma in places like the Middle East, North Africa.
And it arises from MALT.
Yes, it arises from the mucosal-associated lymphoid tissue, MALT, in the gut wall, similar to gastric MALT lymphoma.
And the etiology here seems to mirror what we often see in the stomach, with H. pylori driving gastric MALT lymphoma, infectious trigger.
Exactly. The thinking is that the etiology is likely infectious, driven by chronic immune stimulation from certain bacteria. Associations have been reported, for instance, with Campylobacter jejuni infection. The idea is that persistent infection stimulates the gut's myelin, which eventually undergoes uncontrolled, often monoclonal proliferation and transformation into lymphoma. Early stages might even respond to antibiotics.
Interesting parallel. Okay, what's another key B-cell lymphoma found in the small bowel?
Mantle cell lymphoma, or MCL. While MCL can occur elsewhere, the GI tract is one of the most common extranodal sites involved, and it frequently targets the ileocecal region. This one has a very distinct molecular signature.
Right, the translocation.
Yes. MCL is characterized by the specific chromosomal translocation T11.1 form. This translocation brings the CCND1 gene, which codes for cyclin D1, under the control of the immunoglobulin heavy chain gene promoter, leading to massive overexpression of the cell cycle protein cyclin D1.
And that drives the cancer.
It promotes uncontrolled cell cycle progression and proliferation. Clinically, GI involvement by MCL often presents as diffuse infiltration of the small bowel, manifesting endoscopically as multiple small polypoid lesions carpeting the mucosa, a presentation sometimes specifically termed lymphomatous polyposis. Prognosis is generally poor.
Okay, those are key B-cell types. Now we come full circle, back to the T-cell lymphoma that provides the final dire consequence of unmanaged celiac disease. Enteropathy-associated T-cell lymphoma, EATL.
Yes, EATL. As we discussed, it's rare overall, but it is lethally aggressive, and it is strongly associated with underlying celiac disease, specifically arising from those abnormal clonal IEL seen in type 2 refractory celiac disease.
Occurs in about 10% of non-compliant or refractory celiac patients.
The estimates vary, but it's a significant risk in that specific RCD type 2 population. ETL represents the malignant transformation of those premalignant T cells. It's the ultimate danger lurking in severe, unmanaged celiac. It often presents suddenly and catastrophically with abdominal pain, obstruction, perforation, or severe bleeding.
And the prognosis is dismal.
Extremely poor, unfortunately. Median overall survival is often cited in the range of only 8 to 10 months, even with aggressive chemotherapy. It highlights again why recognizing and managing celiac disease, especially non-responsive or refractory cases, is so critical.
Absolutely. Finally, before we wrap up, we should briefly consider the immune status of transplanted organs, specifically mentioning post-transplant lymphoproliferative disease, or PTLD.
Good point. PTLD is essentially an uncontrolled proliferation of lymphocytes, usually B cells, that occurs in the setting of chronic immunosuppression used to prevent graft rejection after solid organ or stem cell transplantation. It's most often driven by Epstein-Barr virus, EBV infection, or reactivation in the immunosuppressed host.
And the risk varies by organ transplanted.
It does, and what is crucial to note in the context of today's discussion is the hierarchy of risk. The risk of developing PTLD is actually highest following small bowel transplantation, with rates reported ranging from 5% up to 20%.
Wow, that high. Why?
It's thought to be due to the large amount of lymphoid tissue inherent in the small bowel graft itself, the gut-associated lymphoid tissue, combined with the intense levels of immunosuppression required to prevent rejection of this highly immunogenic organ. It just underscores the immense immunological challenge and vulnerability of the small intestine as a transplanted organ, requiring a delicate balance between preventing rejection and avoiding opportunistic infections or malignancies like PTLD. #tag outro. So to synthesize the small intestine's kind of dual role we've explored today, we've journeyed through what is undeniably a critical digestive powerhouse, but it's one that's uniquely susceptible, isn't it? Not just to structural changes, evidenced by that dramatic bile acid dichotomy we see post-resection, but also to these really aggressive autoimmune attacks like celiac disease, and even the slightest shifts in its delicate microbial balance, which is what defines SIBO. Understanding the mechanism of failure, whether it's the loss of the ileal brake signal, or the failure of D-xylus absorption testing the mucosa directly, or the ominous finding of clonal IELs in refractory celiac, that understanding is really the key to successful clinical management.
Absolutely. And for you, the learner, listening in, let's try and lock in those critical takeaways from today's deep dive. Remember that crucial difference. The less than 100-centimeter ileal resection means cholerahic diarrhea due to bile acid irritation in the colon, treated with sequestrants, whereas the greater than 100-centimeter resection means severe steatorrhea due to bile acid deficiency, and sequestrants are absolutely contraindicated. They'll make it worse.
Critical distinction.
Use a D-xylose test as your clean, isolated test of the small bowel mucosal integrity itself because it bypasses the need for pancreas and bile. Remember the crucial need to use PPIs before running the alpha-1 antitrypsin clearance test for PLE to stop pepsin from chewing up the A1AT in the stomach and causing a false negative.
Yes, that PPI trick is vital. And maybe most critically, internalize that severe potential pathway leading from unmanaged celiac disease straight through to the aggressive T-cell lymphoma, EATL. That pathway runs directly through type 2 refractory celiac disease, which is identified by finding those abnormal clonal intraepithelial lymphocytes on biopsy. It's a pathway we want to interrupt early.
Definitely.
And of course, never forget those classic diagnostic signatures we hit. The PAS-positive foamy macrophages stuffing the lamina propria for Whipple disease, and that specific T11.14 translocation defining mantle cell lymphoma.
Right. So we spent today seeing how something that seems relatively simple, like strict adherence to a dietary change to the gluten-free diet, can literally prevent the progression down that pathway to a life-threatening cancer like EATL. Given the strong genetic basis of celiac disease, linked so tightly to those HLA-DQ2 and HLA-DQ8 alleles, and given the incredibly high rate of undiagnosed disease out there. Here's a final thought. How might future public health guidelines potentially use this almost 100% reliable genetic rule-out information? Could we screen entire at-risk populations, like first-degree relatives, preemptively using genetics?
Interesting idea. The goal wouldn't necessarily be immediate diagnosis in asymptomatic people.
Right, not diagnosis, but maybe identification of those who are not at risk versus those who carry the genes and might warrant closer monitoring or a lower threshold for testing if symptoms arise. The ultimate aim being intervention long before severe, irreversible intestinal damage like total villus atrophy ever has a chance to occur, let alone progress to RCD or EATL.
It's a profound possibility, using genetics for preventative stratification on a population level. Definitely something to consider.
Something for you to mull over until the next time we dive deep.